And actually, just Mildred, do you want to just introduce yourself and kind of what the role of the pharmacist is in the care of patients with these kind of conditions, particularly birdshots?
I'm the Associate Chief Pharmacist, so I manage the clinical services. So I've got a team of pharmacists who are directly involved operationally, patient-facing, so you'll see other staff members directly most times. We as pharmacists, we act as I would say as a bridge between the patient and the rest of the multidisciplinary team. It's very, very important that in a condition as complex as this and rare, it's very important that collaborative work is profound. That means for everybody to be talking to each other. So the patient is at the center, and the patient needs to interact with all these different professionals. If they're not talking to each other, it makes the care of the patient very difficult. So one of the things I have been trying to champion in my trust is to ensure that collaborative work does prevail. And I have been doing this through the service, so being engaging with the service at a greater level. We try to ensure that there are good medicines processes for the patient so that the medicines are optimized to ensure that the patient receives these medicines in a very, very safe manner to reduce any potential adverse effects that may happen and make the condition even worse for the patient. So by doing that, we're engaging with the clinicians to ensure that we focus on a holistic approach when we look at the patient. So rather than just focusing on the ophthalmology medicines, we want to know what other medicines for other conditions the patient is on, and we're relying on the patient, on you, to tell us, because when you tell us, it makes the pathway, we can decide what is best for you. As David said, there are potential drugs that could interact very badly with some of these drugs, and sometimes you never know until the patient has experienced the side effect before you realize it. So through that, we try to, in the pharmacy, to take as much drug history as we can, and if it's a case of referring back to the clinicians, we do refer back to make sure that the right choice of drug is given. So the other approach then is to empower you, the patient, to make sure that you take the medicines well, correctly. So we do that through counseling, as Adam has said. So when to take your medicine the right time, what you do if you miss a dose, what you do if you get side effects, if you get into contact with, because most of these drugs that you're using are drugs that would knock off your white cells. So you could pick up infections. So what you do if you come into contact with certain high-risk communicable infections, like chickenpox, high risk in the sense that you can catch it easily. So we have to empower patients to do that. Another approach that I have been trying to develop is how we interact, not just with our clinicians, but the GPs. So we've got a very large cohort of patients who come to Moorfields. They come from all over the country. The demographics is huge. So how do we communicate to those GPs so that they know what we have planned, what treatment plan we have put in place for our patients? And it's very important, if you go to Moorfields or any other hospital, it's important that you have details of your treatment. So GP letters, or in my case, in our trust case, we have developed some monitoring and record booklet. So it gives you details of your dose, your drug, any changes, blood test. So all of that relies on good working relationship between us, the professionals, and you, the patient. So we're asking that those booklets, if you do get them, you carry them with you to your GPs or to any health professionals that you're going to. So it makes things much easier and safer for you as well. So the other thing is regards to GP letters, as I mentioned. Do ask your clinician for a copy of the letter about your treatment so that you can have that letter yourself, so you know exactly what you're doing. You are the patient. You should be empowered. You should know everything that's going on with your care. And finally, I must say, the other point to take note is there's a lot of medicines out there now, lots of generic brands. Do you know what generic? Yeah, I guess you know. Yeah, generic brands, lots of it out there. It's very, very important with these drugs to maintain the brand of medicine you are taking, because sometimes if you switch to different brand, it just upsets your whole system. So you might experience some side effects. So do take note of the brand. If you go to your community pharmacist, make sure you're having the same drugs. Thank you.
Thank you very much, both Adam and Mildred. That's great. So now again, the floor's open, as it were. Any further questions? Yeah.
Many of patients who are on immunosuppressants have to stop temporarily their treatment because they have an infection, they have to be operated, or you name it. Some patients have to stop several times because they have to go through several operations or several treatments for infections. What can be the overall effect of those pauses on the global effect of the treatment? Is there a risk for triggering a new flare or impairing the final result?
Thank you very much. That's a fabulous question, and there's no easy answer. So if I sort of understood to answer, the first one was people have to stop because of infections or surgery. That is, again, a multidisciplinary team approach as to whether that is needed. Not all infections you have to stop treatment, depends what it is. Because the second question you asked, which was, what will that do to your end result, is of course infections themselves can exacerbate the immune system, so you end up relapsing in the disease. So that trigger from an infection, which may have nothing to do with the organ, can drive the immune response, and patients with all different types of autoimmune diseases get relapses. So if we stop the treatment to treat an infection, we are robbing Peter to pay Paul a lot, which basically drives us into an end result that the patient may end up deteriorating. So it's called a stepwise deterioration because of the infections. So there's no simple answer. You're right, it can end up, if you keep doing that, that will end up being worse. But not all infections or surgery mean you have to stop the treatment. So it's about the dialogue, it's about the severity of the infection and where the infection is and what it is. So for example, the commonest would be in women who get urinary tract infections, cystitis. Some cystitis can be quite severe, but it doesn't mean that you should stop the immunosuppression all the time. You just need to get on antibiotics appropriately and treat the infection. If you have a very severe infection, you're so unlucky to get TB, for example, then that's a completely different question where we have to balance therapy with treating with TB. But again, not all the time do you have to stop the immunosuppression. So it's not a blanket response. I'm afraid I can't give you that answer. But it's about what you've heard, a complete decision-making where the patient is empowered and understands that decision that we're making together.
Thank you. And there was a question just from the front row.
Just while you're coming to that, the comment you just heard shows how important it is for you to let whoever it is planning to do that procedure know about the other medical conditions. Because I may not know complete about your eye medications or your eye treatment, and I tell you to stop everything. You're hoping we've been talking. Hopefully we would have been, but you mustn't take it for granted. You really do need to make sure the right hand knows what the left's doing.
So.
Yeah, many of the drugs that we take, from what I can gather, obviously are not designed for birdshot, and usually the patients are on it short term. We're on it quite a long term. I just wondered what the long-term side effects could potentially be. And I know we're covered with our blood samples, and that should, show any alarm bells, but it's just, a concern, certainly for me, that.
Yeah, no, that's such an important question. David, do you want to take first response to that?
One of the easiest answers would be, when you read that information leaflet with the 3 million things that could happen with paracetamol, that truly is everything the drug company knows about that pill. And I often then tell patients, and apart from that, you might take it and for you, something else happens. So if you're not feeling all that well, please let us know. The truth is the list is long, but there are going to be some which are much more pertinent to the individual than not. So for the patient who has a tendency towards diabetes, me putting you on steroids has a specific impact for you. And for each individual patient, before we bring out the cyclosporin, or they alluded to tuberculosis earlier, there's one of the drugs, infliximab, adalimumab, those kind of drugs, we first of all check to make sure you haven't or don't have TB before you go on it. So we know what the likely culprits are, like it's just things that would happen are for each individual patient, and we would look at that. But your question was really, what about the long-term effect? That's a bit more challenging because for some patients, it ends up being short-term because they've responded much better than we thought. For other patients, it's longer term. So at the time you start it, it's not always possible to predict where you will be. But, months, a few years later, we are now also starting to think a bit like you and beginning to look for other things. It's important to be vague about this because sometimes that's what you hear as you walk out. I'm going to get diabetes, I'm going to get TB. And that's never what it was meant to be. But we're hoping that with us talking to each other, we can individualize therapy for that patient and then let them know. But the side effects, as I said, in some of them are quite scary, but the truth is you hardly ever see that in most people. We're vigilant looking for all of it. And we're constantly trying to balance the benefits of that medication versus the potential side effects. So you might find us taking you off a pill because we now think it's not doing your kidneys any good.
Thank you. Can I add to that as well? Because it's such an important question and concern, I'm sure, which is echoed in from many people in the room. There is some data that hopefully will come out from the United States where they've looked at all different patients with uveitis and not just birdshot to look at what long-term outcomes are, not from disease outcome, but from morbidity, what we call the side effects. And in populations of patients with uveitis, undoubtedly we're getting to understand much, much more, even though you've heard about the interim bits, what the longer term detrimental aspects of treatment are. And you compare that with a normal age-matched population. And what we find is unquestionably that too much steroid is not great long-term, and we know that, but that is by far giving the increased amount of ill health later on when taking them above a certain amount for long periods of time. All the other drugs you've seen have been beautifully described as what the side effects are, but indeed when you look longer term, their increase of ill health compared to the normal population is increased ever so slightly, but not very much. So actually, it's about quality of life and balance through great multidisciplinary team working and making sure not much happens in those phases. And if you do that, the longer term outcome is actually quite favourable. The one that isn't is steroids.
Thank you both. Another question? Yeah, just.
Me first.
Yes, sir.
That brings me another question. When is it convenient to completely stop the treatment?
Andrew, I'll get you.
Thank you.
Did you like that? It's a relay button. Another wonderfully insightful question. And again, we're pretty useless up here. There is no answer to that. The great thing we need to know is several things. One is, you are telling us as patients in these questions you ask. The first is, will the drug work for me? We do not have what's called a biomarker to know that's the case, so we treat you and see what the response is. Then we have to know, has that drug worked? So we're a bit better at doing that. And then we have to know, has the disease switched off? And there is no biomarker, we call that some test of some sort, that we know the disease is completely quiet. So therefore, we can't tell you or anybody, now is the right time for you to stop the treatment. So then what happens is we pull back and we look at a population and say, if we look at a population with the same disease, out of 100 people, so to speak, how long does it last and when would roughly be the right time to stop? And again, what happens is you get a mixed picture. So the classic thing in medicine is a third, a third, a third, and that's because we make it up. So a third is, oh, they'll do very well and they'll switch off and we'll be able to take them off treatment. A third carry on for 4 or 5 years and we'll be able to switch off, and a third need treatment forever. And the problems we have and we have to work together is about finding out how long you need treatment for, if you need treatment that aggressively, how long you need it for, and when to stop. At the moment, we just do the normal thing, which is extrapolating from other diseases, which is if you go into drug-induced remission for, let's say, 2 years, if you look at other autoimmune diseases, it would be prudent then to start seeing if we can maintain remission of that disease on lower doses. And then if you carry on, you then start trying to tail off with the hope you don't relapse. But that's about where we are.
Brilliant. Thank you. Lady with microphone just there. Yeah, thank you.
If you do have to come off the drugs because you do get the side effects that you mentioned and you have a gap, have you experienced people being able to go back on the particular drug they were on and not have the same side effects? And also, when they do come off, if you do come off the Cellcept or the tacrolimus instantly, are there any side effects of doing that?
I think it's helpful to have ophthalmologists here, so I can answer in general, and then they can answer about uveitis. Because if we've made a decision we need to come off because of a side effect, it depends on what that side effect was. And for some side effects, it's stop the medication, deal with the side effect, and then go back onto it. There are certain conditions, though, where, as you say, it would seem odd to put you back on that medication with that side effect. So one, for instance, if you were given penicillin and you became allergic to it, we would stop the drug, but we would not put you back on it. We'd be looking for an alternative. So you can use that as, if you like, an example of a situation in which we would not be giving you that same drug. There are some people on cyclosporin whose kidney blood tests now show that the kidneys are beginning to struggle a bit. What I've tended to do is to ask the ophthalmologist, or whoever it is, what's the lowest dose we can get away with? And sometimes going on to that lower dose, you don't actually see the effects. And what we're trying to balance is gaining your eyesight back and the quality of life from that with having kidney function, which is not perfect, but which is actually very adequate. And if you can get that balance, that's fine. You can stay on that same drug, because for quite a few patients, they've been through different kinds of medications. They've now hit on one that works. And to suddenly give that up isn't something they're relishing. So if we can actually manage it with smaller but effective doses, that's what we'd be looking to do, as long as it's not the sort of reaction which was similar to the allergy, in which case putting you back on that same drug would actually be harmful rather than helpful. So that's the general bit, but I think with regard to uveitis, might be.
Well, I think the principles within uveitis will be the same, and again, it's a matter of communication. Now, sadly, it is coffee time. Well, that's not.